Here we go.
The broadcast is now starting. All attendees are in listen-only mode.
All right, welcome everybody to another EBFA webinar series. My name is Dr. Emily Splickle. I'm the founder of EBFA Fitness, and we have a very exciting webinar tonight, a topic that is of great interest to me and I think is really pertinent to pretty much any fitness professional, movement specialist, or anyone who works with patients who present with movement dysfunction. So I appreciate you guys all for tuning in on this Thursday. If you would like to ask any questions at the end of the webinar, you can type them in, and we'll go through some of those at the end. If you want any of the notes, you can always email us at education@ebfafitness.com. And like always, all of our webinars are archived, recorded, and can be found on the EBFA website. So if you happen to want to review this again, or you missed something, or want to listen to a previous webinar, they are all available at ebfafitness.com. So without further ado, I would love to welcome our guest, Dr. Evan Osar of Fitness Education Seminars. Welcome, Dr. Osar.
Thank you so much for having me, Emily.
So Dr. Osar, if you guys are unfamiliar with him, I encourage you to check out his work. Dr. Osar is a chiropractic physician. He specializes in movement-based solutions for chronic pain and movement disorders. Dr. Osar is the author of a very good textbook, which I have in front of me, Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. Great textbook, and again, I highly recommend you guys check that out. He's an international lecturer, specializes on posture, stability, and movement-based approach to corrective exercise. Welcome, Dr. Osar.
Thanks again for having me, and thank you for everybody else for joining in, because I know this is a very busy time of the year for everybody, so I'm excited to be here, so thanks for being with us.
Excellent. So the floor is yours, Dr. Osar, and questions at the end of it.
Change the slide.
Okay.
You know, a lot of our clients have hip, and this hip dysfunction leads into a lot of common problems we see, you know, Emily and I see as doctors, and any therapists that are, a lot of our clients that come in with back pain, knee pain, ankle, foot pain. A lot of these problems are driven from the hip. And what we want to look at is this dysfunction in the hips. You know, why are the hips so dysfunctional in so many of our clients? In this short webinar, what we're going to discuss is we see as problems with the hips, and then what can we do about it? What are some corrective exercise solutions we have to deal with this dysfunction of the hip and joint centration? We'll cover what goes wrong and how joint centration can actually help your clients and your patients, if you're a physical therapist, get improved function, get out of pain, and get to their activities of daily living and sports activities. There. Go ahead, switch the slides. You go ahead and switch. Hello? Sorry about that. Oh, I'll go on. Oh, there we go.
Yep. Are you seeing the slides, Dr. Osar?
Yes. Yeah. Actually, if you can go one back, please. You can slide back. Just go one back.
Are you seeing it, Dr. Osar?
Yeah. Let's look at, especially as it relates to joint centration. If we think about joint centration just for a minute, if you great joint about centration being the ability to maintain an optimal axis of rotation. So again, if you want to think about, you can think about the ball sort of settled inside the acetabulum. So the head of the femur inside the acetabulum, around the joint in an optimal fashion. So you have the deep stabilizers, you have the superficial muscles, and they're all working together. They maintain an optimal axis of rotation. But what happens, one of the most common things we see with hip dysfunction is what we call the anterior femoral glide syndrome. And this is actually when what happens is when you have a tight posterior hip capsule and/or you're over gripping from the posterior hip, and the femoral head is driven forward in the acetabulum. You can see it happens during a lot of our common patterns, as you can see in this slide right here, in the decentrated hip. In the bridge pattern, when people are over clenching their glutes, especially the superficial glutes, what it does is it drives the femoral head forward in the acetabulum, and patterns like the squat, deadlift, lunge, step up, when people are cued to overly contract the posterior hip complex, and they drive the acetabulum forward, and oftentimes you can see the image of me in the right, it'll actually bring the pelvis into a posterior tilt. So again, we have a problem of not only the poor hip centration, but we also have an altered pelvic stabilization. And this creates a lot of dysfunction for our hips. You can switch the slide and we'll see what it looks like in actual function. You go ahead and switch, go ahead with the slides. Next slide. So
yeah, it's a very slow connection, so just bear with
okay.
me.
No worries. In the image to the left, you see probably a Kenyan runner. You can see he's got a perfectly centrated lower hip and lower extremity. So what happens is when his foot strikes the ground, his hip, pelvis, hip, knee, ankle, and foot are lined up exactly. On the image to the right, you see a more classic North American runner. The pelvic unleveling, the slight internal rotation of the hip. You can see the lower extremity, the tibia and the foot actually externally rotate. So again, this puts a lot of stress on the knee as well as through the hip and the pelvis. So this creates a whole kinetic chain of dysfunction because this client has an inability to centrate their hip and lower extremity. So what we want to look at or consider is how do we make these clients more functional? How do we get this runner on the right to look a little bit more like the runner on the left by helping her centrate her hip? Before we go on and talk about exactly why or how to correct this, let's look at some of the things that go wrong. So if you can advance the slides. Because it's important to understand why things go wrong so we can understand how best to correct them. So again, our biggest problem is the anterior femoral glide, so the hip going forward within the acetabulum, usually because of too much posterior clenching. So why do we lose centration in the first place? Well, there are three main categories of why we lose dysfunction. And you can see my crazy grandmother there. She hasn't lost dysfunction. Actually, it's just a picture I found on the internet, which I thought was pretty cool. There's three common reasons we lose dysfunction: neurodevelopmental, trauma, and learned behaviors. And we'll go through these quickly, each of these points here. You can advance the slides. Neurodevelopmental. Neurodevelopmental basically refers to we're born with a certain, let's say, nervous system control. Our ability to control our body is really predetermined at birth. It does not mean that we're never going to be able to change our bodies, never be able to change our abilities, but our nervous systems are set up in a certain manner. Clients, they are very athletic, they're able to get what you say, they're able to perform at a high level of function, sporting. They tend to be the ones that were very good in athletics, whether they were in high school sports players, college sports players, maybe they even made the pros. They're at a high level of neurodevelopment. They have highly efficient nervous systems. And then we have those clients, you remember back in grade school, we have those clients that maybe got picked last on the team. They were sort of clumsy, uncoordinated. Again, not that they had anything wrong, but they were on the lower end of the motor spectrum. Again, that's just how we're born. It's just sort of pre-selected for us. So what Voigt was a physical medicine doctor out of, I believe, Germany. And what he said, he worked with cerebral palsy children, but what he said is that a third of us are born with less than optimal neurodevelopment. It doesn't mean we're going to have dysfunction, it doesn't mean we can't function, but it's going to mean that we're going to have more challenges in our ability to create optimal movement patterns. So that's 1 in 3 of us. So these are often going to be the clients that come to us either as physicians, as physical therapists, or as fitness professionals, because we're going to get those clients that are broken down and not really understand why, but a lot of it's because of their inherent nervous system function. We can still help these clients, but just to let you know, this is one of the reasons why we tend to have problems. You can go on to the next slide. The second group of categories of why we break down is trauma. And trauma comes in many different forms. We have the acute trauma, again, the fall, car accident, but don't forget repetitive trauma. And even something as benign as sitting is a repetitive trauma on our body. Not that the act of sitting causes trauma, but it's the positions we get into from the act of sitting. For example, sitting in a posterior pelvic tilt, which most of us do. Unfortunately, in our field, we think that so many people sit in an anterior pelvic tilt, but most people, if you really look at them, they're actually sitting in a posterior pelvic tilt. So this rounds the pelvis under, it flattens and flexes the low back, actually starts that process of decentrating pelvis and hips. And this will also be made worse or with this if we have tight posterior hip capsule and tight posterior hip musculature. We sit down, we neutral, we stay in posterior pelvic tilt. And that's why sitting is so detrimental to people that have low back pain, because it keeps us in that flex position and it keeps our pelvises tucked under. And don't forget that surgery is a trauma. So many of our clients that are coming to us, especially the females, have intestinal surgeries. So many clients that we see in our are coming in with abdominal scar and dysfunctional core. These clients and their hips. And it creates a lot of problems we're seeing in our clients when they get to see us. So be real careful when we're looking at our clients that if we're going to use a philosophy like that, we think about these clients, or are they with less mental input with so many of our ages of 70 have a very history. So we get questions looking at how is these things, trauma and surgery, affect our clients. And you can advance the slide. The last category is learned behaviors. So learned behaviors, and this is really due to our body over the course of a lifetime. We learn what are our habits, what are our habits, and how does things like exercise affect our ability to stabilize our hips. Three classic exercises: back exercises, the sort of dog, and a barbell squat. None of them in and of themselves bad exercises. But what effect are these exercises having upon our musculoskeletal system? So let's talk. The one thing, the squat is a great exercise. Barbell squats, especially when it's loaded, but it doesn't have to be loaded that high. But just take a barbell squat. If this client's posture, what you see is she's actually hyperextended through her thoracic spine, and she's going to a posterior tilt in her pelvis through pelvis. This is the alignment in the improvement muscles and even her muscles that's very key in both her spine and the hip joint. So what we want to look at not is great exercise, but is there a way we can make it doesn't contribute to in this picture here that we see in a lot of our clients, barbell squats and loaded squats are hyperextending the thorax, spine, and through the pelvis. In the middle image, again, a group exercise class, bird dog, very good for spinal stability if the spine. In this image, you see the female the image most close to us through her lumbar spine as she goes. So again, a great exercise to control her core, because that hyperextension happening in her thoracolumbar junction, her lumbar spine. She's creating more dysfunction at that point to lower extremity problems when she gets into the upright position. And then in the image to the right, again, another hyperextension type position, to squeeze their glutes. Again, this position will also overload the spine in many of our clients because so many of our clients already have over. And when you start to do more of these exercises like this, these clients are just really overloading their lumbar spine. These clients strategy and how to control neutral spine better and not squeeze the glutes so hard that they're actually creating and driving the anterior we talked about earlier. And you can advance the slide again. So what we want to look at with our exercises is not, again, are they good or bad, but what on our musculoskeletal system. So if we look at a child developing, and we're going to use this concept quite a bit in how we you see this client, or sorry, the child, when they crawl, when they move, they generally create points of stability. And the great thing about crawling, in this image right here, what we see is this contralateral stabilization, where the child's left arm and scapula are stabilizing and hip are stabilizing. The opposite limbs, so the right arm and the left hip, they're creating mobility. So we get this simultaneous ability to stabilize and then mobilize segments of the kinetic chain. And this is how we create and set up from the time we're small, optimal movement patterns. Point of mobility. And these areas generally switch. So what happens is when we go into some of these exercise patterns, like the barbell squat and pull-up, just looking at the effect they're having on our musculoskeletal system, they will lock up our system. For example, how the barbell will create a locking of the thorax and create hypermobility in the lumbar spine and pelvis in those clients that can't control it. And if the not controlling these patterns very well. In a pull-up, for example, even though we're talking about the hip, the pull-up, again, we're really using the thorax and pulling the body towards the hand. Again, great exercise, but again, for the clients that's already locked down because they're over gripping, we'll talk about here, it's going to create more locking down. And for the client that has that hip, the anterior femoral hip glide, we don't want more locking down. This industry is a big debate that's going on, is how much do you squeeze the glutes? And we'll talk about that a little bit later, that we have to be careful squeeze their muscles, because many of our clients have do a real good job squeezing. Where they have trouble is letting these muscles. So one of our keys to improving function is not only getting the right muscles to activate, to let go at the right time. And again, also in the category of exercises to learn behavior are some of the cues that we use. So your core, squeeze your glutes, pull your shoulder blades down and back. Again, creating more of that sort of gripping sensation. Very good strategies when we're really lifting a lot of weight. But when we're doing lighter weight, when we're teaching corrective exercise patterns, these cues can actually function, because it teaches the client to lock down and not create and not teach them how to let go and create proper movement. So part of our strategy will be to help these clients get out of their gripping syndromes and facilitate their movement with proper cues for ideal sort of movement strategy. And we'll see what that looks like in the next slide. So you can go ahead and slide forward. Because what happens is we get areas of hyper or hypomobility where they don't move as much, and areas of joint. When we grip too much, it leads to compensatory patterns, as we see in this client here. As she shifts onto one leg, she can't stabilize her pelvis and control her hip, and it leads to dysfunction. If you look at the client's her lumbar erectors and the thoracolumbar erectors, you see how locked up she is through that area there. She's going for just quiet standing, and it leads to hypermobility. And you see the hypermobility showing up down here at her hip, and then you see that internal rotation through her knee just coming from the hip, because she cannot control the hips. So again, we jam the femoral head forward, we lock up that thoracolumbar junction, we create hypermobility on that pelvis and that lumbar spine area, and then we start to create some of our problems. So what are we going to do about these compensatory? Slide up. On to the next slide. What we want to look at is the body's response. And if we think about, again, we can't isolate out muscle systems like the deep versus super. Look at how muscles respond. There's a very specific way the deep muscles respond compared to the superficial muscles. And this is, again, what leads to a lot of our problems that we see with our clients with low back, pelvis, and hip problems. The deep myofascial system, if you want to click forward, that'll bring up the headings underneath deep myofascial. We see the deep myofascial system, when we have injury, it becomes dysfunction in the proprioception, the deficiency. When we have dysfunction of the superficial myofascial system, that tends to become overactive. So all the gripping that we've been talking about, we get. It's an inability to turn their muscles off. And those are the clients, when you palpate their erectors when they're just standing there, they're rock hard. Divoting in their lateral hip region because they're over gripping. What I want to do with our clients is teach them a better motor control strategy. How do you use your hips in a better way? How do you centrate your body more efficiently? Turn off those muscles that are so overactive. And you can progress to the next slide. So there's an inability to turn the myofascial system off because of even some of our exercises and the way we exercise cueing leads to, just click the slide again if you could, leads to these gripping syndromes. Actually look like, briefly, because people have different gripping type syndromes. If you want to go on to the next slide, we'll see a couple examples of it. Abdominal gripper, your client's an abdominal gripper. It's going to look, if they were really fit, they're going to look like this client to the left. He's going to be really gripped down with their abdominals when they're standing there. They're rock hard. This tends to be your more fit population, like your personal trainers. You know, your like lean, fit people that are proud of their bodies. They walk around with their abs gripped up all the time. This is an image to the right of a C-section, so you see a vertical scar there. She's also an abdominal gripper. When you palpate her abdominals, even though she's got some her region, it's rock hard because she pulls, like most females, that they're concerned about their aesthetics and about how they're in their abdomen. So they're going to grip with those external obliques. And again, this is also not just a conscious choice that they're making, but it's also a reflexive choice when we have abdominal surgery. We see this client here, my client with back pain. Here's a client that's never lifted weights, but you see the he has, especially around the thoracolumbar junction. You see what happens when he goes into single leg. You see how active those muscles become. He's your classic gripper. These back gripper clients, they will also become your butt grippers or your posterior hip grippers. You can see in the image to the right where he's actually gripping his hip and creating, and even he's hollowed and under when he's just in quiet standing. You can slide on to the next slide. And here's your classic butt gripper. They come in, this is flying as she's standing in front of me in the line. You see she's gripped, she's got the hollowing through that lower gluteal region, and her femoral head, you even have to palpate her to notice the hollowing. My client here to the left with SI pain and hip pain, he actually is a classic butt gripper. The arrows are pointing, and that superficial glute is firing perfectly. Doesn't need more superficial glute firing. What he needs to do is sort of relax those hips. Quiet standing when you don't need to be gripping. And that's the thing we've been talking about. These clients grip and don't let go. And here's our little gripper. He's just gripped everywhere. And he's a runner that has low back pain and hip pain. And you see he's tucked under. He's got gripping and back gripping. He's just gripping everywhere. So one of our strategies for our clients is really going to be to teach them how to get gripping strategies. You can move to the next slide. What effect does this gripping really have on our bodies? Because again, you're like, okay, so what? Who cares? Here's what happens when people walk around clenched up. And these are two different patients of mine, both coming in with hip. The image to the left is your chronic guy who sits at a desk. So you're a desk jockey. So the middle-aged guy, a little bit overweight, gripping in his mid-thorax or his thoracolumbar junction, and he's got flexion near the black arrow. He's actually flexed in his lumbar, posterior pelvic tilt, that we talked about earlier. These are your clients that sit for a living. Almost all of them are lumbar spine flexed and sitting in a posterior pelvic. He's a massage therapist. He is a fitness professional. Slightly more anterior pelvic tilt. He's not even anterior tilt. For extension again, and you see that lump down in his low back, and again, he's in a lumbar spine flexion. He's over-gripped through the thoracolumbar junction. Gripping those hips real tight, didn't let them go, and that creates flexion in the lumbar spine. That flexion creates more down the kinetic chain and creates more butt gripping because it destabilizes the spine. Let's look at what happens when the spine is destabilized. Short term, when the spine is destabilized, we start to get things like this. We start to get disc herniations. The arrow sort of next to that, like the discs look real healthy. The white area of the spine and in between the vertebrae, you see the white arrow is that sort of black, thinner disc, and that's the early signs of degeneration because of overcompression. Bony changes, we start to create osseous changes to the bone because of overloading and instability. The body's attempt to create more stability around areas of compression. Now let's look at the hip, because we're talking about the hip. Let's look at what happened in the short term. Next slide, please. In the short term, we're going to create a lot of the soft tissue changes we see in our clients with hip problems. We're going to see a lot of, next slide again. We're going to see a lot of femoral acetabular impingement. You start to hear that more and more. So abbreviated FAI, femoral acetabular impingement. And that's where you get that pinching in the front of the hip, especially when you flex, adduct, and in the hip. We're going to get a lot of adductor and abductor strains of the adductors and groin area. And we're seeing more and more and even abdominal strains because of poor hip centration. And again, we're seeing more and more labral tears, and that's an image of a client of mine that who had a tear in his labral. If you do this gripping for a long term, you get what my client has right here. She got a degenerated hip on her right side, and she just recently had hip replacement. She's another classic example of somebody chronic hip gripping, and her femoral head was sheared forward in her acetabulum, and over a year, she's 60 years old, now she has a degenerated going to improve function. Well, we developed the integrative movement system, basically a way to look at the body. There's three central components to improving function. How do we improve function? There's three principles that are inherent to any single athlete, the stay-at-home mom, or the elderly client. Principle number one, you must before you do anything else. You do not teach your client how to breathe and how to coordinate breathing with of their abdominal wall and their core, then everything else they do will be compensations. And that's why just simply bracing up creates dysfunction, because it'll stop and inhibit proper diaphragm function. So again, breathing is essential. If you can improve breathing, you're going to improve a lot of your clients, not only back pain, but also their hip pain. Principle maintain an optimal axis of rotation. So OAOR, optimal axis of rotation. So if the image down to the left, the far left, you see concentrated hip joint. So think of that ball and socket sort of example. When we open the hip, so if we squeeze the glutes too much and we don't let go, we're butt grippers, it drives the femoral head forward in the acetabulum and it starts to create that changes. And if we look at where clients have the most amount of degeneration in their hips, it's the anterior superior aspect of the femoral head. The femoral head starts to rub against the front of the acetabulum. And the image to the right is more of an example of the spine. When we stack and we are able to lengthen and elongate, we rotate and centrate on an axis. We have perfect centration. When we lose that ability, when we go to rotate, we start to create shearing. And that's what a lot of our clients do through their spine. Rather than create elongation and that centrated rotation, that's what that image is depicting to the right. So principle number 2, must centrate. Within the aspect of centration, 2 components, stabilization, dissociation. We must be able to stabilize and control that joint segment, and we must be able to dissociate the joint segment. And we must be able to maintain that ball and socket, so to speak, that optimal axis of rotation, and we must be able to maintain that as we create motion. Squeezing the glutes, for example, as we talked about, we drive that femoral head forward. We lose that optimal axis of rotation. Principle number 3, integration. Once we teach the client how to breathe, once we teach them how to centrate, now you teach them how to breathe, centrate, and integrate the fundamental movement patterns. Fundamental movement patterns, where we're looking at pushing, pulling, squatting, lunging, and stepping. So we want to teach our clients components into all their functional activities. When we're in the gym, we want to be able to teach them how to breathe while they're squatting. Breathe while they're doing a bridge. We want to teach them how to keep that joint centrated. One of the biggest things we're going to look at is reflex. The ankle and foot set up the entire kinetic chain. So again, if you have a client that's had chronic ankle sprains, you work with the foot. And Dr. Emily, she'll probably concur with that. If the foot is not, and the foot and ankle are not right, the hip will not be right. People have delayed glute activation when they've had chronic ankle sprains. And that's why so many of our clients that have hip problems actually have foot problems. The tarsals of the foot and create tarsals and create that foot tripod. We activate the interossei muscles, and with the activation of the interossei muscles creates that extensor chain reflex. We spread the foot out, the extensor chain reflexively turns on. We don't have to squeeze, we don't have to. It reflexively happens when we get the right foot placement. We create that foot tripod, so the majority of the pressure of the foot is over the big toe, the phalangeal joint of the big toe, the digit number 1, digit number 5, the little toe, and the heel. And then when we activate the, Emily talks about this as well, we get the activation all the way through the foot, all the way up the medial stabilization chain through the popliteus, into the adductors, into that deep lower medial glute, and that's what helps to activate and stabilize and centrate the tabulum. If you over squeeze, you decentrate. If you activate the foot tripod and connect to that medial stabilization chain, you get better, especially those lower deep fibers of the glute. Then you take it into your functional patterns, like your hip hinge. So you teach a client how to control their TPC, you help teach them how to align their hip, knee, ankle, and foot, set up that foot tripod, and then create a pure anterior pelvic tilt. Hips without overusing the low back or their lumbar erectors. In the next pattern, on the next slide, then we these things: the breathing, centration, the thoracolpelvic canister alignment, the hip, knee, ankle alignment, the foot Teach a client how to breathe and maintain alignment. You can put their hand on the chest, hand on the abdomen, so they can monitor where their alignment should be if they're loaded up with a barbell, kettlebell, dumbbells. Same thing with a lunge pattern. Align that thoracolpelvic canister, the hip, set the foot tripod, and go through your patterns. Again, making sure that they know how to breathe and centrate their joints as they're going through their patterns. On the next slide, same exact thing. Line up the foot tripod, line up the thoracolpelvic canister, and take them through the bridge pattern. Be careful. Over squeeze at the top of the bridge pattern because they're disrupting the femoral head placement. And again, the argument in the fitness, I should say the debate, let's just call it a debate. The debate is that if you over squeeze or you squeeze a glute, you're getting better glute activation. 100% disagree with that. Yes, you get better glute max superficial fibers, maybe more contraction of those, but you will also disrupt the femoral, get better deep glute activation. And the deep glutes are the ones that pull the head of the femur back in the acetabulum. The superficial fibers pull it back. They're key to stabilizing the pelvis and the hip joint. As far as cueing goes, we have, rather than having your clients pulling your abs, squeeze your glutes, have them maintain that three-dimensional activation of their abdominal wall. Have them maintain alignment, have them activate their glutes without driving the femoral head forward. If you look at the great squatters, deadlifters, kettlebell, they don't drive the femoral head forward in acetabulum through these patterns. They have co-activation. They do not drive it forward and activate the glutes without driving it forward. If you see these clients gripping during their patterns, teach them, rather than teaching them how to squeeze your glutes, teach them how to use the glutes. The glutes can contract. You just don't want to have them drive that femoral head forward and actually go into a posterior pelvic tilt. Are already in a posterior pelvic tilt. They're not anterior tilted. They're actually if they're gripping from their hips, they're in a posterior pelvic tilt. Get them to be more neutral. Teach them how to align, breathe, and connect. In this image to the bottom right, I'm teaching my client how to relax and not grip through the hip flexors, and then getting her to sit that hip back in the socket while she's maintaining alignment. And again, this pattern, no matter what she's performing, the only time I have my clients squeeze their glutes is if they're doing maximal lifts, and only when I know that they're not going to shift my head forward or change the pelvic alignment. So, in conclusion, what are we going to take home as our keys to hip? Number one, we want to understand why things go wrong. You want to just give it a click there, Emily. The reason people is because of neurodevelopmental, because of trauma, because of learned patterns. The central nervous system response to dysfunction grip is to create tightness and stiffness as a means of stabilization. If we follow the principles, if we teach the clients how to breathe, obtain proper centration, and how to integrate that into their fundamental movement patterns, they will have improved function. And always, they're already doing a great job at this, always empower your clients. For most of our clients, this is going to be, or I should say many of our clients, their time with us is a part of their day. They should always leave empowered, keep doing the great work you're doing. If you're looking for further resources, feel free to check out our website, fitnessarts.com. We have tons of free video clips. You don't even have to sign up for our newsletter. But if you sign up for our newsletter, you'll have access to all the new newsletters that we create. We send a new one out about every 2 weeks. And again, they're user-friendly information that you can use with your client right away. Stress up-to-date corrective exercise strategies for training the general population. We work with athletes, with the majority of the individuals we work with in how concepts and strategies is working with the general population, the people that are the most broken down and dysfunctional. A lot of the same clients you guys are seeing. I encourage you to sign up for our newsletter, Fitness Insider. It's a great source of information, and like I said, we really try to deliver high-quality content based on the clinical applications, and like I said, corrective exercise designed for training the everyday client. And if you're looking for a further resource, my book talks about hip dysfunction, how to improve it through corrective exercise, and how to progress your clients appropriately and safely using our concepts and principles of respiration, joint centration, and teaching them how to integrate it into their fundamental movement patterns. I want to thank you guys for hanging in there with us over time. I appreciate your time and your attention. If there's anything I can ever do for you guys, if you have any questions, feel free to, you can let Dr. Emily know or myself know. You can reach me at Evan@Fitness Education Seminars. You can also get to me through Dr. Emily's site. You guys are all fans of Dr. Emily's, and she's really done a lot of great work with helping us understand the function of the foot and how key that is to all other kinetic chains in our body. If your foot and ankle are not functional, the rest of your kinetic chain will not be. Just like if your breathing is not functional, the rest of this kinetic chains will not be. We look at the foot and breathing as a 2 key points to improving function. So I want to thank you guys again for share with you guys. I want to thank Dr. Emily for having us, or for having me here. If you have any questions, we can take a couple minutes and answer any questions you guys have. Any questions that came in, Dr. Emily?
Sure, of course. Thank you, Dr. Osar, again. For anyone who's tuned in, if you have any questions, if you want to type them in on your control panel, you can type them in and we'll go through it. And I read Dr. Osar's book. To me, it's a game changer. I have so many textbooks, like that's taken up my entire apartment. One of my favorite textbooks. And the way that Dr. Osar goes into the concept of joint centration for both the hip and the shoulder, things just start clicking. And, like I had said, it really is a game changer. It kind of opens your eyes. And I wish I had known you before, Dr. Osar, on the anterior superior aspect. So apparently I had a joint centration.
Yes.
So there's many clients who, if they have a torn hip labrum, ask them what part, and if it's anterior superior, then you're heading of poor joint centration. So
for sure. Yeah.
All right, so let me see if there's one. So we have one question from Deborah. She says, please comment on pain from tight fascia contributing to chronic pain for hips, low back, and perhaps shoulder. What do you do to release deeper pain, cover movement without pain? Let's see, do you stretch, muscle development, breathing?
Yeah, that's a great question. Thanks, Deborah, for the question. In our clinic, we do a lot of soft tissue work. As a chiropractor, I do a lot of manual therapy. During our certification course, which we teach primarily fitness professionals. We do get some massage therapists and Pilates instructors and physical therapists that come through, but they're mostly fitness professionals that don't have hands-on skills. We teach a lot of strategies specific soft tissue. So how do we release soft tissue without doing specific soft tissue work? I think the foam roller, of course, we teach a lot of work with foam rollers, balls, different release apparatuses, and I think those are all fantastic. So in lieu of having, I think foam rollers are the next best thing. Along with foam rollers and some of those type of apparatuses, I think it's really a big, in this, especially in the fitness industry, is really getting people to clue into how and where they're contracting and getting them peace from where they're contracting, because most of our contraction is it's a subconscious, but it's at that subconscious level, so that conscious control it if we get our brains in touch with the area to relax the tight musculature. So say you're foam rolling the posterior hip contracted. What we want to do is not as you're foam rolling or right after you're foam rolling and you're doing maybe a hip hinge or something like that, improve their awareness of that area, get them to start to relax through that posterior hip region. Give them an analogy of something like in a socket. Give them spreading between your sits bones. Give them a verbal cue, and you can even tap on the area. Say, I want you to relax under this chronically tight area. So do your foam releasing, your foam rolling, releasing that you're currently doing. Give them that feedback to facilitate their brain letting some of this muscles go, so that when you teach them these new patterns or teach them an improvement, that they have a better awareness of how to contract and a more optimal ability to stabilize and centrate that joint and create better patterns. Because a lot of our chronic movement dysfunction or chronic pain syndromes are coming because of how people are centrating and how they're moving. You can improve joint centration. You will take away a lot of your clients' discomfort. And again, don't get hooked on pain so much. One thing I'm trying to get myself is not to get so hung up on pain, but improve the movement. As the movement improves, as a joint becomes better centrated, most of your will start to experience less pain. We use a foam roller. Again, if you like stretching, I'm not a big fan of stretching, but I will use it. And I use the techniques you already know, but don't forget about the brain's control of those muscles. Get into their nervous system, help the client get better. Even the clients that have really poor proprioception can improve if you just sort of cue them in, figure out, a visual learning, your own body, what you mean by relaxing, and that will really help your clients release a lot of this chronic. Will change a lot of your clients' chronic pain patterns, and you'll be amazed at how much better they will feel just by improving.
Great. Thank you so much. If anyone has any last-minute questions,
for sure. My email is Evan, E-V-A-N, at fitnesseducationseminars.com. Feel free. Concerns that you guys have, I'll be happy to answer them. And again, if you have any questions, feel free to ask Dr. Emily, because as you guys understand, she focuses on the foot and looking at things from the foot up. I focus on the core. I'm a big focus on that down. But again, we're both looking pretty much at the exact same things with our approaches, and what we're trying to call it that or not, we're all trying to achieve joint centration, creating that more optimal joint placement for more optimal muscles around it. So again, I really want to thank you, Emily, and thank your listeners for allowing me to be on here and give me the opportunity to share. And feel free to send me any questions.
Great. Thanks so much. Thank you guys for tuning in and taking the time out of your Thursday. As a reminder that webinar, if you want to Osar's webinar again or check out any of the past ones, please check that out at the website, EBFA. And then we have our webinar series first Thursday of every month. January, I am doing one on barefoot running injuries, how you can use progressive evidence-based barefoot training techniques to reduce injuries in your barefoot runner clients or athletes. Thank you again, Dr. Osar, and thank you, everybody. Have a wonderful weekend.
Thanks so much. Take care.
Thanks.